CPD. Tonight, we are incredibly fortunate to have Adam Dobson with us, and Adam is a highly respected spinal specialist physiotherapist working in the NHS. You might also know him by his moniker, the Ridiculous Clinician. He has an MSc in Advanced Clinical Practice, which was achieved with distinction, and he is one of the leading voices in the debates around contemporary management of spinal and radicular disorders. He's led in the development of loads of exceptional quality patient-facing resources, so thank you for that, Adam. We've used a lot of them at our trust. But let's give a warm welcome to Adam Dobson, everyone.
Well, thank you very much, Sam. I don't know where you got that information from, but that was
We
very
have our ways,
nice.
Adam.
Yes, you have your ways. I'll say that my logo's been added there as well, so very clever. Yes, if you've got any questions or if you want to make this interactive, please do. I can't see any faces with the new updates with Zoom. And it's nice to know that there is someone there, uh, kind of responding and thinking about what I'm saying. Um, so NEMS have kindly asked me to chat to you about an interesting topic that will feed into the cadaver event, and that is foot drop. It's an interesting topic. It's something that I will see fairly regularly, and it's surprisingly quite kind of deep in terms of things that can cause it and things to think about. And it's not something that I've seen a great deal on really, other than that it exists and it's concerning. The question is, what do we do with these patients? Where do they go? What constitutes an emergency versus urgent referral? Who do we refer them to? It seems to be one of those things that we know it's important, but we haven't got quite consensus on what we should do with them, and where they should go, and what the sequence of workup should be. So I've thought about that quite a lot, and we're going to talk about that today. This works. So yeah, I think there's a QR code here. There's one at the beginning. There's one at the end. Please do offer us some feedback, and we are keen for you, if you attend this session, that you see the merit in maybe attending the cadaver session. I'll be attending that session. I put a day's annual leave in, and hopefully there's a little bit of connective tissue between this session and the cadaver session, that what we do in some applied anatomy, that you can then relate to what these things really look like in the flesh, as it were. So yeah, foot drop differentials, don't let it trip you up. So these are the things that we're going to talk about. The top two are probably fairly familiar and for good reason. But there are other reasons for foot drop, and there are some concerning reasons for foot drop. And I think that we need to be able to identify those zebras as they crop up. Polyneuropathy, it's certainly something that we're aware of, but when it comes to neuropathy and polyneuropathy, it probably isn't in our traditional training to be thinking about polyneuropathies. It tends to be more the mononeuropathies and the radicular symptoms. So what the heck are we talking about? So you'd be surprised to know, or maybe you won't be surprised to know, there's no universal definition for what constitutes a foot drop. If you look at the BMJ article by Stevens, they would say it's a weakness of the dorsiflexion muscles of the foot, and then I put in there anterior tibialis and extensor hallucis longus. But it's pretty vague. It's not very objective. Do they mean a little bit of weakness? Do they mean profound weakness? It's not quite so clear. and you'll struggle to find a definition that tries to pin that down. Now, in my training and my estimation, a foot drop is pathognomic with an overstepping gait. So if you have an overstepping gait, one would think that you have a profound weakness. If your foot's floppy, if you're having to lift your leg to clear your toes, then one would think that the weakness must be substantial. And my kind of stick in the ground would be anything under 3 on the MRC scale. So they can't resist gravity. And when we test, that would be my feeling of how we define a foot drop, 3 or less on an Oxford scale. Now, it is a clinical sign, so it's associated with lots of different conditions. So when you look at the data on prevalence, there's lots of different populations of people. Um, there's lots of presumptions, and it's really difficult to know how common this condition is, because they don't tend to focus on the sign as much as they focus on the condition. And we know that when it comes to lumbar radiculopathy, for instance, there is a massive heterogeneity problem there already. So it's quite problematic to know how common this issue is. And it's seen as a sign of a number of conditions rather than, a condition into itself. The most common cause is stated to be peroneal neuropathy. Now, I find that quite surprising. I work in a specialist spinal clinic, so perhaps I am biased to seeing more radiculopathy than peroneal neuropathy. I'd be interested to know, maybe put it in the comments, if you work in primary care, because one would think that if you work in primary care or you see undifferentiated cases, that you perhaps see more peroneal neuropathy than I would do. But the evidence seems to suggest that peroneal neuropathy is the most common reason for a foot drop, and it's often painless, isolated, and they usually have sensory patchy numbness. So it's generally a painless foot drop to opposed to a painful foot drop, which would probably indicate more of a radiculopathy. So today's focus is going to be more on that sudden acute foot drop, those undifferentiated cases that come in. We're probably not talking about pre-existing foot drops or things that maybe are associated with hereditary neuropathies. So one such example is Charcot-Marie tooth disease. So they typically have high arches, as you can see in this picture here. They have that claw toes, and that's a type of polyneuropathy, hereditary polyneuropathy. It's the most common hereditary polyneuropathy. And that would suggest that it's an ongoing condition. So they've not just developed this foot drop, and that will obviously change your management of those patients. Similarly, muscular dystrophy, patients with stroke, ongoing kind of differentiated cases. They're probably a little bit different to these kind of sudden onset where we're deciding what to do with them. It's a time-sensitive condition. So what I mean by that is that if we come across these acute foot drops, these undifferentiated foot drops, then then time is against us. We need to make decisions quickly. We need to get them to the right people. They need to do the right workup. And the reason that's relevant is if the axons are on sufficient compression for too long, they'll degenerate, and there's a potential that will not resolve. So has an implication on your function, your quality of life, your work status, your mental health, lots of reasons. So it's a serious pathology, and it's something that we need to be acting on fairly quickly if we identify these patients. These aren't patients that will go, well, let's just carry on with the physiotherapy, for instance. Just out of interest, these there's my definition at the top. These are just three people who've known or thought to have had a foot drop through painful radiculopathy. John Thaw, um, bonus points for knowing uh, who John Thaw acts as. It should be an easy answer to that. Put it in the questions in the Q&A. There's a bit of a question mark about John Thaw. Was it hereditary? Was it a perineal neuropathy? But if you look at some of the older recordings of Inspector Morse, when you zoom out, you can actually see that he has an overstepping gait. And the urban legend is that they would always film really close to him because he didn't want to be seen walking with an overstepping gait. So that's just an interesting thing. So what are the key signs? Um, there's a couple of things that these all have in common, and these are things that we are kind of pretty consistent with foot drop. So I'm going to put that on mute. So this is my old man. He's simulating an overstepping gait. Um, and if we look from the side, you can see slapping the floor. So patients, you often hear them before you see them. So slapping gait, um, lifting that knee up. We should always be examining our patients, and this is what you might expect with a foot drop. Okay, so can you move your ankle up and down? Put down there. As well as that, we want to be assessing for ankle, the ankle strength or ankle dorsiflexion. Always look at their active range of movement first, and then it's very easy to check this in sitting. So this is kind of the key test. Do it in sitting compared to the other side. If you have normal strength, there's no way that you should be able to overcome that. Let's just show you that one more time. Josh, if you let me know about time, let me know when we're halfway there, etc. So we're going to hold it up, middle of the foot, secure the knee, push down. Very simple. Do it in sitting. It's easier. You can do all the other testing in sitting. If you struggle with that, then we can also do it in long in supine. So the patients laying down, don't try not to have them long sit and get them completely flat. You can get a good pull on the legs with this one, so don't be afraid. You can also test resisted toe extension in this position. So take it on. Can they hold that position? There's no point doing the resisted test if they can't hold the position to begin with. So can they hold that position? Yes, and then apply that resisted test afterwards. So do this if you're not able to do it in sitting. A couple other things as well. You want to be inspecting the legs for muscle atrophy um, around the lateral aspect of the lower leg, the posterior aspect of the leg can be a pretty important tell. If there's sufficient radiculopathy, sufficient conduction loss, then the muscle you atrophy pretty quickly. So you definitely want to be looking at the legs in the skin where possible, in standing as well as someone asking a question, and have a look at them in laying down. Have a look at their thighs, see if there's any significant wastage. Is it localized to the perineal area, for instance. Okay, so this is something I've been playing about with for probably about a year now. I've adjusted it and come back to it a number of times. And I'm just trying to picture those constituent parts of the plexus, the various nerves that plumb the sciatic nerve that are relevant to foot drop and often relevant to radiculopathy. So I'm calling this the sciatic neuromuscular pathway, and it's relevant to radiculopathy, it's relevant to plexopathy, which I have to say is not common outside of trauma, and then mono neuropathy as well. So we have the roots. Technically, these are the ventral rami, but let's just go with the roots for ease, simplicity. Then we've got the lumbosacral plexus in the middle there. That's what that is identifying. Over here, we have the superior gluteal nerve. So that innervates the gluteal medius and minimus muscles. So that's an early branch coming off from the plexus. In the middle, we have the sciatic nerve. So the sciatic nerve is technically a bundle of two nerves, the perineal division and the tibial division. So this will be quite interesting to see on these cadavers, if you how chunky that structure is, and if we could potentially see those two bundled nerves together. And then we can see the epineurium of the sciatic sheath. Moving further down, we've moved to the back of the knee. So we're in the posterior aspect of the leg, the popliteal fossa. Then we've got the common perineal nerve, and then we've got the tibial nerve that innervates the triceps, responsible for your S1. And then we've got the common perineal nerve is moving, wraps around the fibular neck, which is where it's quite vulnerable, it's quite superficial, there isn't much padding around that area. That then gives rise to the deep perineal nerve and then the superior perineal nerve that innervates those muscles responsible for dorsiflexion, big toe extension in particular. Okay, painful radiculopathy. So when we're talking about foot drop, we're mainly talking about the L5. Um, Dorsiflexion is the TA, the tibialis anterior, does have some contribution from the L4. But it's probably more relevant to the L5, and you'll see that stated uh, more commonly. So we've got those foot drop components, the overstepping gait, the profound ankle dorsiflexion weakness, which is 3 or less out of 5. Um, I would probably say that radiculopathy is the second most common reason for a foot drop, but we haven't got much data to go on. That would just be a hunch on my part. It usually is disc related. It's usually spontaneous. So we can see that that yellow jaggedy line is representing a problem at the L5. It is occasionally precipitated by an event. But what I tend to see in clinic is that they're usually spontaneous, these things. A patient will be brushing their teeth and will start developing pain into the leg. Okay. So these are the relevant kind of weaknesses that you would expect. So we've got dorsiflexion, big toe extension may be weak. And then there is a kind of an ancillary kind of innovation from ankle eversion and ankle inversion. So with these things, it's kind of weakness at the hip on the buttocks and mixed weakness at the ankle. So with these, they have a little bit of a contribution from all of those levels, the tibial nerve, the deep perineal nerve, and the superficial peroneal nerve down the track. But importantly, there will also be weakness uh, potentially with there'll be some kind of impact on the superior gluteal nerve. Now, what I would refer to as the elusive L5. So with an L5 lumbar radiculopathy, if you're unsure what the ankle weakness is representing, um, lay them on the side, check hip abduction. Okay. The elusive L5 is hip abduction because that can be affected um, by an L5 nerve root, as you can see from the picture. They may also, well, they will often always have spine-related leg pain, reflex loss, could be hamstrings, which is not routinely checked, occasionally patella. The L5 does occasionally crop up with patella tendon reflex testing, hyposthesia, paresthesia, dysesthesia. So all of those typical radiculopathy symptoms, but then we have the foot drop and then the elusive L5. So if you're unsure, check hip abduction. Just a little bit, video for you here. So have the patient onto the side. We should always be checking their available range of movement first. So have them actively take their leg up. And if they can do that, we then want to be testing their isometric strength. Always compared to the other side, probably do the other side first, and then compare what normal is for that patient. As well as that, if you're struggling, you can test this in lying. So you can test both together. It's a little bit more tricky. I'm using a foam roller here just so I can release their heels a little bit, and you can check hip abduction. If the patient can't get onto their side for whatever reason, but you think it's still worth checking, then you can check it on the side as well. Good long contraction, and that might be useful, might give you a little bit of a clue. Okay. Sciatic neuropathy is a type of mononeuropathy. As you can see on the picture, I put those yellow squiggly lines again. And just to give you an indication of it could be there could be a problem at the buttock, it could be a problem within the leg itself at the posterior thigh. It's a rare cause for foot drop. A true sciatic neuropathy, just kind of walking through the door in a spinal clinic to me, I've never seen one. Never seen one. If you work in orthopedics, you may encounter these a bit more than I would do. So buttock trauma, hip replacement, prolonged immobilization, occupying lesions, could be a reason, nerve sheaths, tumors, abscesses. There are some case studies to show that in rare cases, endometriosis can lead to sciatic neuropathy. They are rare, but it's something that we want to be at least considering in foot drop patients, particularly those who have pain. So these are the things that you would expect essentially. The knee down over, including knee flexion, will be weak. So these have what is referred to as a flail foot. I'm not sure if you've came across that term before. So a flail foot is essentially where everything is weak in the foot. Okay, so not just ankle dorsiflexion and big toe extension. They've got weakness with inversion, eversion, big toe extension, and plantar flexion as well. So with these patients, there's clearly something a bit further up the chain going on. But importantly, um, these should not have weakness in the hip abductors. So this is again why that can be an important test. So again, here are those divisions. The tibial division does your hamstrings via the semitendinosus, which is why it can be weak when you have a sciatic neuropathy. And very occasionally, you can get in there with a reflex hammer and check the hamstring reflex. Um, I do that occasionally, and if it might be as well as checking hip abduction, you might check if they've got it on their involved side, their uninvolved side, compared to the involved side, and it might just be a little bit more information to reason through what's going on. So they may have buttock tenderness, they'll have burning pain in the lower leg, their Achilles, and potentially their hamstring reflex via the tibial division will be off. They'll have diffuse hyposthesia, dysesthesia, particularly in the sole, but importantly, they will not have any associated lower back pain. The second mononeuropathy, the most common reason cited for a foot drop is a peroneal mononeuropathy. So they've got the overstepping gait, they've got the profound weakness with dorsiflexion. Causes for this: trauma to the knee replacement, a fracture to the fibular neck, pressure, bracing, plaster casts, habitual leg crossing. So that might be something to ask and observe. Patients, people who squat a lot, cross their legs a lot, who kneel a lot with work perhaps. A Baker's cyst to the back of the knee. Again, prolonged immobilization. And there is something as well called Slimmer's palsy. So quite interesting with the Manjaro weight loss injections is that there is some case studies to show that patients taking those medicines have been going on to develop a foot drop through this Slimmer's palsy. So essentially, just makes your peroneal nerve a little bit more vulnerable, less padding to the lateral knee, and a bit more susceptible to compression through things like perpetual crossing of legs, for instance. Um, this is what you would expect. Mohammed's raising his hand. I don't know if you want to pose a question to me, gentlemen.
So, Mohammed, if you want to put a question in, I don't know if you've done so already. No, it doesn't look like it. You can just put it in the Q&A at the bottom of the screen, and we can go over that either at the end or that can be answered sort of like in situ. Everyone should be able to access that. Um, just because I don't think you can unmute, Mohammed, that's all.
Yeah, and I don't quite know what the what the question is, whether raised
Yeah,
hand on its own.
Yeah, I tell you what, Mohammed, if you put them in the if you put it in the question and answer, and then we can perhaps take a bit of time at the end to answer that, if that's all right. That should be at the bottom of your screen, where sort of like audio and video and whatnot is. All right.
Lovely.
And we're just at half time as well, Adam. Just to let you know, sorry, just while we're here.
Lovely. So yes, significant weight loss was we talked about, didn't we? So with peroneal neuropathy, their pattern of weakness would generally be ankle dorsiflexion and ankle eversion. So pretty much in isolation, potentially big toe extension. Um, Hip abduction is preserved because that's done by the superior gluteal nerve. Ankle inversion is spared because it's predominantly done by the tibial nerve. With these patients as well, you would not expect them to have any areflexia. You'd expect their reflexes to be normal. So that's so if you've got a painless foot drop, um, they've got weakness with ankle dorsiflexion, eversion, their inversion, and their ability to push up through the heel is intact, and their reflexes are intact. Then one would presume this is more likely to be a perineal neuropathy than a painless radiculopathy. They'll also have this kind of patchy numbness over the front of the foot, so into the toes and into the second and third toe. Maybe patchy. They may be atrophy to the lateral aspect of the lower leg. They may have pain with palpation through the nerve trunk of the superficial and common perineal nerves. So it's maybe worth having a little palpate around that area. But these don't generally tend to be painful, or at least the pain will be more isolated to the kind of shin and calf. As well as doing that, as a part of our assessment, we would need to do some enhanced tests. Ankle eversion is quite tricky because sometimes it's tested in dorsiflexion, and clearly they have a weakness in dorsiflexion. So check ankle eversion in a plant flexed position. Big toe extension, again, if you fix the middle of the foot or have it in a more neutral position, you might be able to check if they've got if they can resist your finger against the thumb. But again, that might be tricky. It might be not possible to check, in which you would just you would abandon that and just document it in your notes. And then we've got ankle eversion, which should be fairly easy to do because it's preferentially tested in a plantar flex position. And then single leg heel raise is fairly easy to do. Shouldn't affect that to be affected. As well as so we talked about radiculopathy, we talked about mononeuropathy. Now we're into the slightly less common types of things. This is called a mononeuritis multiplex. Now, what that basically means, mono means a single nerve, a single peripheral nerve trunk. Neuritis means inflammation, so inflammation of an individual nerve. Then multiplex refers to two or more unrelated nerve trunk involvement. So it will not be symmetrical. It'll be there may be a weakness in their arm, and then a weakness in their leg. As with this picture, they could have a wrist drop, radial nerve palsy, which accompanies a foot drop. They could have patch of numbness on the hand, and then they've got a foot drop on the contralateral foot. So these are unrelated nerves, and they're kind of not symmetrical. So that's key to this mononeuritis multiplex. It's usually caused by a type of vasculitis, vasculitis. There's a number of these polyarthritis nodosa, rheumatoid arthritis can be involved, a number of secondary infections, HIV, hepatitis, Lyme's disease, malignancy, diabetes, which is quite rare. So if you see any of these conditions in your patient history and they've presented to you with an acute weakness in separate parts of their body, including foot drop, then it may be that they have a mononeuritis multiplex secondary to some of these conditions. So multiple isolated nerves are affected. It's asymmetrical and asynchronous. And what that means is that they could have a weakness in one leg, and then 2 or 3 weeks later, they could develop a weakness in a different nerve in their body. And interestingly, over time, these asynchronous nature can become synchronous. So they can actually look like polyneuropathies. They can look like bilateral foot drops. But in actual fact, it's just a sequence of steps where they've started with one weakness and then it's developed and appears to be bilateral and synchronous. So I've got a video here. This person has polyarteritis nodosa, and this is a late stage. This is a synchronized mononeuritis multiplex presentation. There we go. So this gentleman was thought to have a polyneuropathy, was later found to have a mononeuritis multiplex that had synchronized with later stage development. So it's presenting as a bilateral foot drop, but it's presumably a coincidence that it affected the perineal nerves bilaterally over time, presumably. Then we get onto the polyneuropathies, and they tend to be length dependent. What that tends to mean is length dependent means that they often occur towards the periphery of the trunks. So we're talking about feet and hands, some more distal symptoms. They tend to be symmetrical, and you've heard of that stocking distribution of pain, numbness, neuropathic pain in diabetic patients. But all of these things, diabetes, alcoholism, vitamin B12 deficiency, chemotherapy, all of these things can lead to length-dependent polyneuropathy and potentially with severe degeneration of the axons, it could lead to motor axons, could lead to a foot drop. That's not necessarily going to be bilateral, but in the late stages, there are patients with these conditions who can develop foot drop. So typically sensory predominant numbness, tingling, burning. They often have like a type of sensory ataxia. They often get sensory proprioceptive changes, notably in B12 deficiencies, often metabolic, toxic, nutritional based, gradual over time. One would think it manifests unilaterally, but it could manifest bilaterally. And it's a late stage kind of manifestation of the symptoms. Now we have a pretty nasty condition called Guillain-Barré syndrome. It's an acute paralytic polyneuropathy. Now, the important thing with this is that the symptoms often develop very quickly. They often develop from the bottom up. So they may develop a weakness in their lower legs that generally tracks up their body. And that may include drop foot. These may have bilateral symptoms, and obviously bilateral foot drop should always be concerning. And this is a potential uncommon reason for that. So symmetrical ascending weakness in the legs, in the arm, to the face, and it can include bilateral foot drop. Interestingly, these often have diminished reflexes. So this is a peripheral nervous system condition, demyelinating nervous system condition. So when you're testing their reflexes, they maybe in a young person, for instance, where you'd expect the Achilles and patella reflexes to be fine, they've bilaterally got an absent reflex response. So it often develops quickly. It peaks at 2 to 4 weeks. It can develop and start as weakness in their legs, reflex loss. And these are people that we need to be acting on because it can lead to early death. I'll just leave this up here for you to read, but you can develop foot drop with motor neuron disease. These have mixed upper motor and lower motor symptoms, so they may have a foot drop owed to degeneration of the motor axons, but they may also have mixed upper tract signs, spasticity, hyperreflexia, Babinski's, all of these types of things, clonus. So if you have a patient who has a foot drop and they have concomitant, convincing upper tract signs, that there may be a concern of this kind of condition. Just a picture here showing you some fasciculations. So another reason why you want to be looking at the legs and their arms, make sure they're undressing, that you may see fasciculations in the thighs or the calves, and that can be a feature as well. This can be common in healthy individuals as well, but it's just another part of the picture. Few honorable mentions. If you have a major trauma to your lower leg, you can develop a palsy, you can develop a foot drop. Importantly, with this group, they may be susceptible to limb ischemia, secondary to compartment syndrome. So remember your 6Ps. In this picture, the person's got a pretty pale leg. So if you meet a patient with a traumatic based foot drop, and you feel there's sufficient evidence of acute limb ischemia, then these need to be seen as an emergency case in case they lose the limb. Central conditions, MS, stroke, these things can develop foot drops, but it would tend to be a number of other symptoms that are cluing us in to the nature of their problem. But they may have MS and then they may acutely develop foot drop. So it's worth thinking that it could be related to a central condition. And then lastly on the honorable mentions is things like functional neurological disorders. So I've personally encountered patients with this condition, weak legs, heavy legs, apparent weakness in the legs. It's probably within the realm of possibility that they could develop with an apparent foot drop. And we need to be thinking about that kind of broader picture with those as well. So these are just all reasons. So just putting that all together, looking at the past medical history, looking at the presenting complaint, looking at the examination findings. Take a picture of this one if you want to. It's a good slide, just encapsulates all of those various elements when we meet patients who might have foot drop, who have foot drop clinically. Whilst at the same time, just remembering that when you hear hoofbeats, think horses, not zebras. So the most common things are common for a reason. So the perineal neuropathy in the painless cases, radiculopathy in painful leg cases, they're clearly more common. So if it's fitting a common condition, if it looks like a duck and it quacks like a duck, it's probably a duck. So do bear in mind these other kind of differentials, but always remember common is common for a reason. So what do we do with them? Are we okay for time? Yeah, it should be all right.
We've got 15 minutes left.
Is that for the whole thing, including questions? I'll
Yeah.
whiz through. So what to do with them? So first of all, just remember that this is serious pathology. It's time sensitive, differentiated or undifferentiated. They always need onward referrals. They almost always need investigations. So what do we do with them? Bilateral foot drops, acute foot drops could represent metastatic cord compression, Guillain-Barré syndrome, I wrote DBS, don't know where I've got that from. Occupying lesions, motor neuron disease. If a patient comes in with an acute bilateral foot drop, in my book, they are an emergency or same day opinion patient. We refer them to, we take them off to accident emergency. We speak to our colleagues. We get an opinion from registrar, an on-call registrar if we work in a hospital setting. Trauma, similarly, if they are at risk of acute limb ischemia, and you're concerned that they might develop acute uh, compartment syndrome, then we need to refer those. We need to get those patients seen as an emergency day case. Acute unilateral cases, if they've got signs of upper motor neuron involvement, the fasciculations, pathological reflexes, patchy, those are the depends kind of cases. So if we have definite features, we have concerns, it's more than reasonable to think that they would need a same-day emergency review. Beyond that, if they've got kind of non-specific sensory symptoms, but these clear tests are negative, then we might need to refer them urgently to neurology, to opposed to a same-day emergency review. Urgent referrals, acute or subacute unilateral foot drops, painful, most likely to be radiculopathy. They want to be referred through your relevant pathway to me. In this case, it's quite helpful to consider preemptive imaging. So if you're in a position where you can order imaging in primary care, for instance, I would find that very helpful in this particular case because it's time sensitive. Refer them for urgent lumbar spine MRI scan and then refer them to the relevant neurosurgical or spinal pathways. Painless is most likely to be a perineal neuropathy, and you want to refer them to either neurosurgical services or the neurological services. I'd probably say neurosurgical services in most cases. If the weakness is more than 3 out of 5, then arguably within the wider context of the presentation, from the weakness perspective, then we could consider wait and see. Just quickly want to talk about electrodiagnostic tests, nerve conductions, and then needle EMGs. Nerve conduction tests tend to be when we suspect mononeuropathies and polyneuropathies. Needle EMG is sometimes used in conjunction with that, but it's more useful if there's a suspicion of radiculopathy, but it is an invasive procedure. Lastly, there is a plan, GIRFT. There is no information available just yet, but I feel that it's common knowledge to say that there is some plans with GIRFT to develop a foot drop pathway. It'd be very interesting to see if that has consensus with the things that we've mentioned earlier. But this is an area that I think that we need definite consensus on. We need definite guidance and pathways, and we need to kind of join up all those systems. So just want to say to finish that I do have a 6-week course coming up, Mastering Lumbar Radiculopathy, 6-part online course, QR code at the bottom there. Some of this stuff will obviously form part of that. So if you're interested in learning more about painful lumbar radiculopathy, then please consider checking that out. Questions? Josh? Samuel? I've gone very dry.
Yeah. Hi, Adam. So we've got a few questions coming into the Q&A function so that the chat doesn't work. If you have questions, please put them in there. So we'll just take them from the top. So the first question is there any difference between an oversteppage gait and a high steppage gait?
No.
Nice easy one to start.
Yeah, I would tend to, you hear that term oversteppage. Oversteppage is a kind of term that you will hear often. overstepping, high stepping, oversteppage. It's just a case of they've got the John Cleese type. It's a case they're trying to not catch their toes. So they're consciously or subconsciously lifting the knee to clear the toes to stop from tripping or falling over, which is obviously a hazard with these patients.
Fantastic. So the next one, Adam, can I ask what the pathway might be for a traumatic foot drop? So they put in brackets a drunken fall from FCP. So a few weeks, not progressive, no pain or tenderness from the fib head.
So it's painless. They've got a foot drop, but it's painless. There's trauma. So we want to check their vascular integrity. We want to make sure that they don't. There's not any concern about acute limb ischemia. So the six Ps, pallor, pulselessness, perishingly cold, which is technically something called poikilothermia, paralysis as well. So we want to be checking muscles up and above the ankle as well. Just as we've said on that thing, these need an urgent review. So if we're concerned about vascular compromise, they need to be seen as an emergency case. So it might be a letter and straight to accident and emergency or through a registrar if you work in a hospital. Obviously, talk these things through with your colleagues. If there aren't any concerns about those things, we want to safety net our patient from a vascular perspective, and we want to be seeking an urgent referral through neurosurgery.
Brilliant. Slightly more difficult question. What is the prognosis for mononeuritis multiplex?
I think it kind of depends on the underlying etiology. It depends on the reason that underlies that condition. So there's a number of vascular reasons, rheumatoid arthritis. The short answer is I wouldn't be sure on that. If they've had the symptoms for more than a year, 2 years, if they've got an ongoing foot drop for more than 2 years, the chances are it would never recover. Um, but yes, that's a very good question. To that, I'll put on Twitter.
Bro.
Does it go back? Does PNF influence neuroplasticity and motor read? Not really sure I understand the question, to be honest. I'm not sure that PNF stretches has any role to play in the management of foot drop. What I would say is that you want to be encouraging ankle mobility to prevent the foot from becoming stiff. So get them at the wall, stretching that ankle. Maybe some sensory techniques if they've got sensory, if they've got hyposthesia. They may also be helpful to include an orthotist for some kind of foot device as well as a short-term remedy to prevent them from falling. So I think that over and above getting them to the right people, getting the right investigations, that's really the limits to what I think physiotherapists should be offering, really. Education, preventing stiffness in the ankle, potentially referring them to orthotic departments, and absolutely getting them to the appropriate team who can investigate that as soon as possible.
Brilliant. Next question is, what about prognosis? It's another one about prognosis. So if a unilateral foot drop goes to surgery, I'm assuming they mean, does it return to normal afterwards?
It all depends on how much capacity they have for axon regeneration. So if there is irreversible conduction loss, then perhaps not. But many patients, I think this is why these operations, the sooner the better. So the sooner we understand the nature of that problem. So I had a patient who had a ganglion cyst around the common perineal nerve, and she'd had it for some time, but then as soon as they removed the cyst, she had almost full resolution. So that would indicate that there was venous congestion, but the axons were still intact, that there was reversible conduction. But you can't really know that until you do it. You can't really know what that person's capacity is. I'm not sure that the research is that granular to answer those kind of questions. Certainly, when it comes to lumbar radiculopathy, um, we don't have enough data to be that granular because we can't look at the inside of the nerve. We can't know what the physiology of the nerve is from a clinical perspective.
Brilliant. So I guess it's a case by case basis from what you're
Mhm.
describing. We certainly don't have time to get through all of these, so I'll try and just pick one last one. I think this one would be quite helpful. So would providing an AFO or foot up splint be helpful in an acute foot drop situation to prevent any further traction on neural structures distally?
Good footwear, definitely, and an orthotic to prevent the foot from the toes from dropping down. If that's what we're meaning by the AFO, then yes, absolutely, very sensible, and something that we can do.
Brilliant. And if people have further questions for you, is there a way that they can get in touch?
Yes. So I'm on the socials. I'm on Twitter. I'm on LinkedIn now, Sam, which is an interesting place. At Adam Dobson 123, and I think it's at Adam Dobson 123 on LinkedIn. I am on Instagram, but I'm not don't go on there a great deal. And also, if you've got questions about courses and things, through my website, theradicularclinician.com.
Brilliant. Well, thank you very much, Adam. I think we've just got another couple of slides, I believe, after this.
Mhm. Yes.
Brilliant. Thank you very much for that. We all learned a lot, I'm sure. So just as a reminder, we've got our NEMS conference coming up fairly soon. It's on Friday, the 19th of September this year, and we'll be releasing the tickets and speakers fairly soon. Just as a reminder, if you could provide your feedback for today, we do look at all the comments that you make and try and make adjustments to what we do based on that. So your comments, however big or small, are really valuable to us. If you could please take just 2 minutes to give us some feedback. If you were interested in the cadaver event, I think last time we checked, we had around 10 tickets left, so they're nearly all gone. There's a QR code to access that if you are interested, and that's on the next slide. But thank you all for joining us. Thank you to Adam very much for sharing his clinical pearls and wisdom with us. Like I said, you can get him on socials and on his website, theridicularclinician.com. And if you're around in the cadaver event, I'm sure you'll cross there.
Thank you very much, everyone. Um, it's been nice to chat to you, kind of.
Yeah.
Hope that's useful.
Fantastic. All right. Thank you very much, everyone. Take care.